This is a study that has been coming into being for a while. There were a lot of discussions on where PL-HIV movement in terms of owning some of the spares that we haven't ventured before in our region to be part of our work and guiding strategies at the end of the day, because a lot of times we see information coming out of researches, studies, or national reporting, which we believe at that time didn't really reflect what goes on in our lives. And then there was this call of action among our partner networks, initially from 11 countries, that, okay, this is about time that we should start, doing something about it. And then in 2010, we got together and put up this proposal to the Global Fund, which was, interestingly, cut down by 90% upfront. So we got what we want, but only 10% of it. And then the challenge was to make it a reality and to prove that it'll work and it could be useful. And that's what we're trying to do. I'm going to share a few things out of this huge study, about 8,000 samples, 400 plus variables. So it is a lot of data to go through. So I don't want to bore you too much or overburden you, but I'm going to run few critical things that we believe are important. The objective, as I said, was to monitor in a more formal way the issues related to access to treatment, moving out of conventional thought process of, okay, legal barriers, sustainability and availability of ARVs, which are there and very important. We also felt that there are issues that are very individually driven, which needs to be addressed as well. And then we thought maybe we can monitor it in a longer term and see if we've seen progress or lack of it. So that's basically the idea behind the study. We looked at a number of things, but it starts from the diagnosis till the care at the end. I'm going to focus more into diagnosis and early markers for this presentation in the interest of time. So this study was done among 7,843 respondents from 7 countries in Asia. We wanted to call it Asia Pacific, but we ended up having only Asia, so we left that term behind. In Bangladesh, Laos, Nepal, Pakistan, Philippines, Vietnam, Indonesia. And the data collection was conducted in late 2012, early 2013. Analysis was completed later last year, and it's still ongoing because it's, as I said, it's quite a sizable study. It was interesting. When we talk about lack of access, we also talk about how hard and challenging it has been for the service provider to reach people in the communities. But then we realized at an onset that it's actually a challenge for us as well. In some countries, if you notice in this chart, we could not even enroll 10% of people from the community. We had to rely on a lot of hospital-based enrollment. And it's ironic to point out that now is because the idea is for communities to bring healthcare closer to the people who need it. We're actually sometimes just relying on whoever comes into the hospital to take it over from there. And then that yellow bar in Laos suggests that like 91% of respondents were actually enrolled from the hospitals. The percentage varies across the country. In Pakistan, where access to treatment is very, very poor, a large majority of respondents were recruited from community. Very few transgenders. That's what it was expected. But we have sizable data from transgenders in Indonesia, but literally non-existent in other countries. The risk categories are very diverse across 7 countries. For Philippines, it's more MSM. For Indonesia, it's drug users. For Vietnam, it's drug users. For Bangladesh, it's international migrant workers. I mean, look at why would people are being tested. It's quite interesting to know that a lot of these HIV testing are clinical or non-self-initiated testing. A lot of people get tested because their husband or wife or spouse or partner gets sick. A lot of people are being tested because they are going overseas to work. If you look at want to know, in some countries like Indonesia, it's sizable, like 40%. But with Laos, it's like 82% of those tested were because their partners or family members gotten sick already. It is, I call it a misleading slide, but it's an important one to point out. A lot of countries, they're only going to the government hospitals, and it's also because there are no other service available. So it looks like government hospital provides majority of HIV testing in countries like Laos, Pakistan, but in Bangladesh, the ARVs and all the services are provided by an NGO, so that you see the access to the NGO testing site is high, but I think it's more of a service availability issue than the choice of site. This is very interesting for us because that's what we've been trying to tell. It looks like by the time people are diagnosed, this is self-reported baseline CD4. A lot of people question that, and I find it funny because sometimes it seems like we think people who live with HIV, we assume, the systems assume that they don't even know what their CD4 cell count is. I'll show you data later on that some percent of people don't know what ARV is. But we had a pretty good response on baseline CD4 cell count, and what I can tell from experience is people absolutely remember what their baseline CD4 cell count is. Rural people remember it much more than urban people, the urban participants do. And then the baseline mean or even median, if you look at it, like based on 2010 recommendation, it's already most of the countries are falling below it at diagnosis, and we thought it's probably just the issue with AIDS. Maybe HIV diagnosed 10 years ago had to be a lot lower than now. It's actually not true. Let me skip some. This data shows people how long ago they were diagnosed and what their baseline average CD4 cell count is. And if you look at it, if countries hasn't got better, it's actually in some countries gotten worse. So people who are recently diagnosed also diagnosed of very low CD4 cell count. This is the access to viral load test in these countries. 98.8% of people in Bangladesh haven't been through a viral load test. Countries like Laos and Pakistan looks good, but it's also one of those countries we have very low diagnosis rate, and the treatments are being provided in government hospitals, tertiary care hospitals. Cost of healthcare, it seems like people spend a lot of money in their healthcare, even though HIV is supposed to be a disease that is supported by a lot of donors. It may not be a lot of money, but if you compare that with their average income, it's almost like what they make a whole month they spend on their healthcare every time they get hospitalized. Treatment literacy, not so much of an issue in some countries. Some countries like Nepal, still like 50% of people have poor treatment literacy. 6 out of 6, I believe, countries are still using stavudine, except Bangladesh. In some countries, it's quite high. Self-reported ART. This is a bit tricky thing to share, but I believe that's the problem with measuring adherence. This is self-reported adherence based on a 1-month recall, and it seems like for countries are below 80%. Conclusions. No, HIV self-initiated testing is something that we've been talking about, but I think we can demonstrate with the data now. I must caution that this isn't observational data, so we're trying to not be careful, not creating a cause and effect interpretation out of it, but it looks like any way we see it is still like, when people are diagnosed with HIV, they're already in healthcare setting seeking care for illness. Despite large-scale funding, people still have to pay out of their pocket to get themselves treated for other diseases, which are commonly occurring. So the ways forward for us is to take it forward and make sure that it becomes one of the considerations for new fundings, because it seems like a lot of times funding goes to traditional mindset, and a lot of times nobody really want to do early diagnosis or put people in care early on. The data suggests that a large majority of people will already be in care program or ARV program if it's now new WHO recommendation guideline for 2013. And we also want to make sure that we keep on build this experience and take it to a next level and see if we can monitor changes over time to see if we can establish a cause and relationship, cause and effect relationship in a long run. This is, as I said, a very big study that we've conducted, and there's a lot of information that you can see from the website. The website's still on progress, but the download page is there where all the country presentations are. These are the organizations that were involved. Thank you.
Can I just ask that we keep all the questions to the end, so save them up and write them down?
Yeah, thank you, Sushil. I think that really does set the stage for the discussions today, because a lot of times we say that we have to develop programs based on evidence, and so it's good to begin for us as communities to be involved in the data collection process, so that our advocacy agenda is driven by evidence and by data collected on the ground, and that gives us a stronger place from which to begin to move our advocacy agenda along.